Good morning, Sohaib.
Good morning, Arnaud.
My name is Arnaud Lemmers. I'm a gastroenterologist working in Erasmus Hospital in Brussels, and I'm heading the endoscopy unit here.
My name is Sohaib Ouazzani. I'm also a gastroenterologist in the same department at Erasmus Hospital in Brussels. Firstly, we would like to thank endoscopy editors to have the opportunity to present our recent study entitled Digestive neo-epithelialization after endoscopic stenting for upper digestive complete disunion. This study was carried out in collaboration between Hôpital Nord in Marseille, France, Marc Bartet, Jean-Michel Gonzalez, our surgical department, Jean Closset, Imad El Messaoui, and our gastroenterology department, Jacques Devière.
So at the origin of this project, we had some opportunistic cases where at the time scheduling a patient to treat a leak after upper GI surgery, we observed by surprise at the time the scope was going in the patient that there was a complete disunion of the anastomosis. Then discussing with the surgeons, we decided at the time to attempt stenting to try to restore digestive continuity, draining the collection and going for stent sessions up to the time the problem was solved. And I propose you to discover the following case.
This is the case of a 49-year-old woman who, many years after a vertical gastroplasty, underwent a Roux-en-Y gastric bypass for morbid obesity. This last surgery was complicated by a complete 3 cm esophagogastric junction necrosis with a complete loss of luminal continuity, with floating remnant stomach in the middle of a peritoneal cavity full of pus. Using a double-channel therapeutic gastroscope, the disconnected gastric stump was deeply catheterized and a guide wire was pushed in the deep jejunum. A 12 cm, 23-28 mm self-expandable partially covered metal stent was inserted and deployed from the jejunal limb, pulled back to cover the 3 cm long leakage and the distal esophagus on 15 mm on length. A second 10 cm, 23-28 mm partially covered metal stent was deployed in the proximal esophagus to secure the stent upward. Under antibiotic, the clinical evolution was very good. Upper GI study showed no more residual leak at 25 days. Oral nutrition was resumed before the removal of the surgical drains and discharge. Clinical evolution was optimal up to 8 weeks when the stents were removed by the stent-in-stent technique. Seeing the status of old necrotic cavity with beginning of re-epithelialization, a new stenting cycle was initiated using two 12 cm, 23-28 mm partially covered stents. These stents were removed by stent-in-stent technique 3 months later, and endoscopy showed a neo-epithelialized digestive continuity connecting the esophagus to the remnant stomach with no more leakage seen at the contrast injection. Nevertheless, the patient developed grade 4 dysphagia, secondly to 2 strictures located at both edges of formed stents. These were successively treated by 3 endoscopic dilation sessions with dysphagia resolution and no more sepsis recurrence. On these pictures, we can observe the impressive neo-epithelium covering the former abdominal cavity, creating a regenerated esophagogastrojejunal digestive tract. Mucosal biopsies showed normal cardiac mucosa with esophageal and esogastric epithelia.
So as you understand, we clearly demonstrated here a proof of concept that when there is a diversion of the fluid allowed by the stenting between the upper part and the lower part of the GI at the 2 sides of the complete disunion, and we drain the collection, treating the infection, it's possible to restore a digestive continuity. And we observed that there is a neo-epithelialization alongside the stent. So this is clearly a proof of concept that we can, of course, use in very difficult cases in our endoscopy unit instead of major surgeries. Thank you very much for your attention, and thank you for endoscopy for publishing our work.